the recording, you'll see that coming up. Thank you. Very helpful. So want to welcome you all to the first meeting of our new session, starting obviously September 26th. And so I'm going to turn it over to our beloved chairperson, David Nagel, who's going to go through the roll call. And for the new people, this is not just a boarding, we actually have.
Yeah. So welcome, everybody. It's great to be back again. This is an important meeting because it's going to help us set the direction for where we go. The bad news, I have pharyngitis. The good news, I don't have to talk much. So we're going to start with the roll call. We use ROLE.
Yes.
It was a mistake at first, but then we thought we're going to explore everybody involved. It's important. So hard in the ROLE is the right one.
One of my few typos that worked out.
All right, so here we go. First, Alexander Sosnowski. Send a spell.
I hear.
How do you spell your last name?
Yep, it's SOSNOWSKI.
Yeah, I thought it was misspelled. Thank you.
Thank you.
Thank you. Adley Saku. Andy Hashman.
Here online.
Thank you. I have to ask a question. Are we supposed to ask people why they're not here? Because for some committee.
I think technically, we really leave that up to you.
We were doing that in the past. I'm not sure if, I believe we're still running the same way, so we did do that in the past.
So we did do it in the past? Okay, so now I just say, why you couldn't make it, just for the record. Ann Landry. Ann Potocek.
Potozak. I'm
Okay.
online. And I'm not here because I have a meeting that's abutted up to both sides today.
And, thank you.
We're not like being like jerks about it. It's just help. We kind of.
No, makes sense. Because I'm only down the street, so I really should be sitting there.
Now, the way the street is, I wouldn't blame you for staying.
Trying to figure out, this is your first council meeting?
Yes,
Congratulations.
oh yeah, thanks. I was volunteered by CSI.
Congratulations. It's a good place.
Well, welcome, man.
Thank you.
Oops, Anna Thomas. Benjamin Hilliard. Beth Daniels. Bobby Bagley. Hear me?
I am
Bob?
present and I'm not able to be there because I have a meeting with my supervisor, the mayor at 2 o'clock.
A fine excuse.
It's not acceptable because I like seeing you. I just joke. I mean, I do like seeing. Christine Brennan. David Nagel, that's me. David Rochford. Deirdre Daly.
There she is.
Yay. Oops,
We just called you on the roll, D.
she just showed up. Deidre. We just need
I
to.
am here. Thank you.
Okay.
Apologies for being late.
Oh, it's all right. You actually perfect. Jennifer Johnson. Jeremy Roberge.
Here, and I'm on doing it virtually because of meetings before and after. So, and subbing in for Monica O'Clair.
Thank you.
Very thankful.
Josh O'Meara. Justin Romanello. Kim McNamara.
Here.
She's here. I knew you. Lauren Pearson. Margaret Pritchard. Sorry this is taking so long, but I do it. Martha McLeod,
Hi, I'm here and I'm not in person because it's actually my day off.
oh,
Ah,
It was a long ways to drive to Concord for something to, so I'm here.
let's see, Mary Reed. Hagan. Sorry.
just give me the way.
Really? Oh, good. Nobody says my age anymore. Maria Boyle. Congratulations, your first meeting. Good job. Oregon Harris. Phil Slutton.
Jess Williams, I'm here today in place of Phil because he's out of the office, and I'm online because I had an online meeting directly before this.
Thanks, Jess.
Campion.
I'm here online because I have back-to-back meetings.
Shirley Tomlinson.
Here.
We just covered. Sat in your old roles and shares to make sure you're. Suzanne, oh gosh, Golosher. It's in there.
Here, I'm here.
Did I say that right?
It's Gallagher.
I
It's a
thought
tricky
right.
one.
Suzanne Prentice. She's recovering from it. Oh. She's just.
Yeah.
Actually, I can't. Tori Jennison.
I am here online due to a schedule conflict. Thank you.
Tricia is on.
Trisha's on, present, required to be in Keene, currently the administrator on call.
Ah,
Goodness. Whitney Hammond. Here. Got her form. I'm so proud of you guys. And Bill Palmer. Good job.
excellent, yeah. So welcome the folks that are in person new and those folks that are online that are new and then the rest of the folks. So did we miss anybody? I think we've got a couple of.
I was fast.
Justin was fashionably late. Yeah, we'll mark you down. That's fashionably late is FL, so we'll put the FL.
I had to remember that. Great risk.
Dr. Chan is in the building, and then we have the Groutman Barnett. This is right. Okay, for our members of the public.
Thanks. I just wanted to say, we don't have the minutes from the last meeting, which is a little bit of a darn shame because we have a quorum, we voted on them, but we don't have them to be available next meeting. I'm staring at the guys gonna do.
That was my bad for not sending those out for people.
That's it.
I am a whip, a work in progress.
So I'm gonna turn the meeting over to you.
What?
He did an awesome job of the survey to help us get a really good direction of where we're going and a good action plan, because it's really. So I would turn it over again.
So I'm going to shout out to Tori, who she's one of the folks in our leadership group that got together to put this agenda. It wasn't certainly anything I did by myself, and just said we probably ought to talk about for the council. I'm actually going to have Whitney talk a little bit about this transition between Brandon stuff.
Yeah, so I know some of us are newer, some have been involved in this effort since the beginning, I think in 2019. We've kind of, over the years, the department used a contractor to facilitate counseling. So we originally used UNH and CHI, and that was Joe Porter and Katie Robert. And then we transitioned, we went out to competitive bid, and we ended up selecting Brandeis as our facilitator. So that was for the last year of council meetings. Due to a lot of, now it actually feels like it's, well, no, it's just as chaotic, but it's a different type of chaos. We were very uncertain about our funding availability because this was the support for this SHIP council. We used some federal funding. And so we made a decision to pull in the facilitation of the SHIP council, like internal to the department, not from like a leadership, perspective or to direct this group, but to provide the support, in between meetings and to be the people that, members can reach out to if you have needs or questions. So we thankfully have Scott Foster, who's going to be the sort of day-to-day supports. Many of you talked with him over the summer because we're gathering input about what worked well over the years and areas where we might be able to even strengthen the work of the council. I'll definitely be continuing on the council as a designee. And then I imagine as we continue to figure out how best to utilize this council, and I think that's part of what, Scott's conversation will be about today, sharing inputs from council members about where they want to see this council go. We may then identify additional DHHS staff who can come in and provide additional support, whether that's our data team. If we end up saying like, we want information at a state level to inform our work. It could be like, so Bronwyn's here, she's our cancer program person. If we started to dig into that as like a health outcome, we may tap them. Ben's here as our state epidemiologist. So I think we do have a lot of capacity at the department that we can just help support this council in their work.
Excellent. So thank you, Tori. I just checked with people online to make sure that our owl was working and you were heard perfectly. So that's great.
I just wanted to say that the feedback that we got was really important. This group has potential, really. We want to make sure that's the case. And I really appreciate the effort. And I think this is a good move to do what we're doing.
Well, I hope at the end of the meeting, you all feel the same way. Some of you may be like, where's Palmyra? What's her telephone number? So I just had a couple of facts I wanted to throw in for our data people. Shout out to those folks like Jess that really kind of love the data. We have 35 total council members right now, some obviously more active than others. We have 4 vacancies, which I won't read. You can see those. And we did have the New Hampshire Providers Association close. So that was our typical we were at 4. Of the 35 council members, which I thought was actually a pretty good number, 20 folks attended at least 4 of the 6 meetings. So that to me was, you are a dedicated group. As somebody who sat in the gallery next to Bronwyn for all of last session, that was certainly the impression that I got, was you're all here because you want to be here and you want to make a difference. There's some other attendance figures. The most we had, I think, was about 26 folks. That was actually in November, believe it or not, which is kind of a strange number to have the best attendance. The most we had in person was our May 20th, which we made a real effort to do, but we got a pretty nice group in person here today too. And then in general, we average about a quarter of us that show up actually in person, but most of it is online for all the reasons that we heard all of you talk about. I especially like Bobby's version, like I got to meet with my supervisor. I'm not going to be late for that, but I understand.
And if I could add to like, this has come up. The reason why we pushed the legislative change was because it's important that you're doing your job. We're not stealing you from there, and that we have a broad representation for the entire state, not just this area. And the only way to do that is by changing the form requirements. And this is a good way to do it. So,
so a little background about the interviews. As somebody who was new to being your support person, I didn't feel like I knew any of you really well. I had obviously been to meetings. And so Woody and I went to Dave as the chair and Ed as the co-chair and brought the idea to them. We even actually ran it. We interviewed them and kind of made some changes to the questions. And again, I really just want you all to know the purpose of it was, it's not to blame Brandeis or just to lay anything at their feet. It was just more like, what do we do now? What do people like, what they did, and how can we change it moving forward? I just want to be, really perfectly clear. So we asked folks how their involvement on the council benefited their organization. We got 15 folks to actually come forward out of 35, so a fair amount. About 43%, I think, folks decided they want to do this. And really what we heard was, you get to come in here, hear information that's brought to this group, you get to take it back to your folks. you get to have those networking opportunities, which I think this group was doing a lot better in May than we started in September. And then one of the things we heard loud and clear was this group, as I think Dave just mentioned, this group has a really great opportunity to influence on behalf of all of the organizations you work for and all the people that you represent, planning for both HHS and then also on a larger state level. What I want you guys to do is please feel free to put in the chat, speak right out loud. If you have any input, again, this is what 15 people thought, but I'd really like to hear from the folks that are on the call, from online and also the folks that have. So if you feel differently or if you want to chime in anything about these questions, we would welcome you to do that. You don't need to raise your hand. It's a pretty informal process. So then we asked the turnaround question is, how do you think your participation benefits us? And I think it was all about your expertise. We've all had conversations outside of these interviews about, we bring a certain piece. I look at Justin because again, he brings that piece that he has that nobody else has. All of you do that. If you all have a piece. And that's the reason why I think Dave was just mentioning this group's potential is because I don't know about any of you, but I do a lot of groups that are singular. It's like cancer groups, or I do a heart group or a diabetes group. This group has 35 different places that you come from and people that you actually have that you are responsible for bringing forward. So I was curious about this because we know, the SHIP is kind of a big overarching 4 large domains. It's not really specific. I thought I had reached out to Polly as somebody who was, and a couple other people that have been here since the beginning. And it was interesting that Polly said, we talked about this when we were creating the SHIP, that we didn't, it went back and forth. Is it broad? Should it be broad or should it be specific? And then again, I think there was this place where people were saying, if we get really, really specific, people will be able to find themselves in it. I don't know. Feel free to correct me, Polly, if that was not the point of that conversation. But I think the point is we have a broad SHIP and people are using it when they create their own plans to try to make sure there's some alignment. They share the updates that we share here with their folks. And then really connecting with all of you that are experts. I know Dave has mentioned several times, I have legislation. I want to know what you think about that from this point of view.
Okay, just
go ahead. Of course. It's all right.
So, one of the big issues for me a lot of times in a group is like, who's not here that needs to be here, and then how do we get that voice included? It may not be, that's a statutory change to get them as part of the group, or is the group too big already? But that is something we need to think about. I think that's like, how do we hear their voice?
Yeah, and actually interesting, trying to make myself familiarized with the actual statute. It's in the statute that, as especially as the chair and co-chair, but we can reach out to anybody that you feel like you need information from. They don't have to be a member. So I think it's interesting that the creation of Trish Tilley and folks that kind of dreamed this idea from the beginning, they thought to put that in there, that if you need something, it doesn't have to be from an actual council member.
Yeah, and that to me that's really critical, because just interacting with the health networks and things like that. It's a lot of.
Well, you're actually foreshadowing, Dave.
I'm sorry.
That's okay. Yeah. Yeah, please.
What council members get from their involvement in this group. And she said just being in the know about state health in New Hampshire and best practices in public health prevention across the state.
Thank you, Suzanne. Appreciate that comment. Improvement, what would you assess for the SHIP? And we asked, it could be for the SHIP plan itself, or we also asked if you have improvements for the SHIP council, which we are. I don't think people feel like we've really reached, again, talking about those public health networks and communities. We haven't reached out beyond ourselves. Jennifer, that's okay. And then when we do kind of have information, how do we make it easier to find? We do have, and again, Megan was a part of that conversation. We had a little conversation with our leadership group about, there was a New Hampshire Lives Well website. That original website isn't in existence anymore. We have a DHHS website, which we link to. So if anybody has any trouble when they put in the original website, they don't get to us, they can let us know. But it's not the same. And I know some people really like that old one, so we certainly can work with the website that we have to make it help.
So that was one of the things that we had talked about was, I think subcommittees have a lot of communications subcommittee. And that would be part of their role. Their other part of the role would be to reach out, get out and reach out, figure that kind of thing out. And it's a two-way street.
Yeah, and I think for those folks that have been around a while, there was a community engagement work group in the beginning. There actually was a group that worked, was intended to work on that. It kind of fell by the wayside. So we can always resurrect that if that's what the council wishes.
I should say also the website, actually, I found it by accident. It was very easy. Just
as far as the HHS one.
Yeah, really easy.
Yes.
Put in.
But again, I mean, I think not to the work that Joe Porter from UNH and Katie Robert did from CHI, where it was a nice website, and if people want changes, it is not the easiest thing to do, but we can do it, and we should. That's what people want. So we heard a lot. You'll see this on other sides about stronger leadership. So we, as a council and a movement, need stronger leadership and a clearer purpose. And really wanting plans to be turned into action instead of just, and a lot of that came from the presentations that were held, before Brandeis took over, and then we did have some presentations last year, but maybe working as a council to try to find more things that people can actually turn into action. And then this is those things, and by the way, nobody would ever invite me to a metrics group or a measurement group because that's not my strength. But how do we find those clear ways to measure progress? And this did come up on several times. It's like, is it something that we do where there are things that are going on in your groups and your partner groups that we just actually find a place to fit in the ship, and then they're measuring them already? We don't have to create new ways to do that, because creating measurements as a group is quite painful. And I know did some great work, Phil did some great work, all the people that were in that measurement committee, but it's very hard to come up with things because, again, we're not taking all the action items. Mostly all your partner groups are doing the action items. So something for us to think about is, do we actually try to find those things that are happening in the state, make them part of the ship, and then really we're not measuring them, we're just collecting those measurements.
Since nobody else is saying something.
And please feel free to say.
No, I have this bad habit. I never heard this term till a month ago, but apparently I like to boil the ocean. Basically I was accused of that at my med school and but anyways, I wanted to create a program there that was pretty extensive, and they accused me of that. We can't boil the ocean here, but we can't focus on important things in terms of making change. So that's gonna be, I think, that to me was the leadership issue, was what do we want to focus on? How do we do it? There's a million problems out there.
Yeah, I mean, I oversaw the Brandeis contract, so if there were things with Brandeis that went wrong, I was just as responsible as anybody else. But I think it was just a lack of, they really kind of focused on the report, and we didn't change that. So, but really, I think you'll hear as we go further, I don't think the report is where people want to spend their time.
And I think that's why it's important to have our leadership, I'm sure people, not some, not a state.
And again, Katie and Joe been around this state for a very long time. It was different. You all were creating a plan. The biggest problem came when we created the plan, and then now we're done. What do we actually do with it next? It was a great thing to create the plan, but it's just now working as next steps.
Hi, it's Bobby. I'll just
Bob, go ahead.
Yes, I'll just chime in on the plan. So for those that are in regional public health, our regional public health regions. So a directive that was given to us that our public health leads are to use the plan to align when we do our local or regional CHAOs and CHIPs, to make sure that some of the that our CHIPs align with the SHIP's goals and for direction in some of the activities that we plan in our communities. And so I think that's one way that the SHIP plan is being used.
Yeah.
I don't know if there is a if there's going to be a measure or metric to determine how effective or how efficient we are as regional public health leads to do that. You know, I don't know what mechanism we're supposed to put in place to report back out on that.
Yeah, and I think we'll kind of see that. You're doing a great job of foreshadowing too, but I think it's like, how do we work better with those regions to either, again, try to highlight those things that are already going on, but how do we measure back and forth? How are those things feeding up into SHIP, and how is SHIP kind of feeding back down to that? But you bring up a great point, and was really a predominant point that people brought up as far as like, yeah, we do use the SHIP as a guide, and I think that's, you know, I'm not speaking for you folks because I didn't do it, but that's sort of what it was intended to do.
May I just ask Bobby a clarifying question? Were you asked by someone from DHHS as a regional public health lead to use the SHIP as a guide, or is that something you're doing because you've been part of this group and you're aware of it?
Well, it was given to us as a directive when we did our work plans for each of the elements that were funded under. So for our public health emergency preparedness, or for BDAS, to look at the SHIP and identify, you know, a priority area there, and then create our work plan and include some of the SHIP goals in our directives for the year. So, and I mean, I was kind of doing it anyway, Polly, but to me, it just makes sense, right? If we're leaning towards, you know, getting to overall big picture, New Hampshire lives well, you know, we want to, at the local level or in our regional levels, at least look at, you know, how we can address that. Since we were trying to get the data from all of these different members in the community to formulate this, it only made sense to me. So that's why I was excited about it. And then it did show up as a directive. This is when, I'm not going to remember her name.
Alia?
Yes. This is when Alia.
Alia,
This is when Alia was a part of, you know, this work, and then she was also a part of the regional public health networks. And so it just made sense to me. I don't know how easy it is for other regions, though. We have a fully functioning health department and I have community and I have program leads doing some of these things. So we have a little bit more staffing capacity for some of this, and then we do it through our FAC as well. I don't know how that is done or interpreted across the state with the other regions, though.
Great, thanks. I just in the very beginning, when we were assessing who was doing what and what coordination might exist, most of the CHIPs were pretty disparate from one another. So that's helpful information. Thanks a lot.
Well, and to Polly, to both Polly and Bobby's point, like, we may be able to use either myself or, again, other DHH staff to try to figure out a little bit of an evaluation piece as far as how that process is really going, and what are the, you know, some of the issues, because I'm sure it's not perfect by any means. So, thank you.
Oh, me? Oh,
Sure.
Yeah, my vision, I just think you learn more from the street than you do from the office. And I just would like to see this be more of a two-way street. Yet I don't really want us to be dictating down to you all coming here and then reverberating to back out to everybody. And, you know, everybody does great things that if people are disparate and really not aware of what other people are doing, this may be a mechanism for this guy is doing this good, this guy is doing that good. We bring that information back and you all have access to that.
Yeah, and I think, again, not quite to this point, but again, the data that we're talking about, I think a lot of people felt it wasn't very effective what we had. We couldn't really talk about SHIP in a way that people really understood. And then again, we're still going through those same pieces of, we don't have a clear goal, we don't have a plan. And again, there were several people that mentioned both older adults and people with disabilities are missing from the SHIP. One of the problems with the SHIP is it doesn't have a lot of specifics in it. I mean, so it goes along with, other than I think mentioning maternal child health a bit, there's not a lot of specifics. So that's, you know, kind of one of those things that I'd like to figure out. Yeah, go ahead, Ken. Sure, go ahead.
So I just wanted to add in from like a department perspective, I'm glad Bobby brought that up. I was definitely co-crafting that approach with Alia to say like, let's align with the ship. And then I just wanted to kind of give a little bit of a foreshadow to work that Dr. Chan and I have been, and Scott as well, have been working on at the Division of Public Health level of developing our own, you know, you could think of it as an internal strategic plan, but also aligning that with the ship and having indicators and kind of to Suzanne's input earlier, like then thinking through what's the evidence, like what's the data look like in New Hampshire and what are the evidence-based approaches to move the needle on this? And then as like another tie-in, one of Bronwyn's roles at the division is to actually help develop a statewide particular plan around cancer and cancer outcomes. And I think she's been wrestling with like, how do I also build that with alignment to the ship? Because I know if you've been working in this world long enough, you know, there are 8 million plans in New Hampshire. They all are in different places and it can be really difficult to like figure out that intersect. So again, we're making a real effort to use that ship, the ship as an alignment.
Can I just make sure I understand what you meant by plans? Do you mean like individual groups plans, insurance plans?
Oh, individual groups. So like there's like the plan on, there's like an aging plan, there's a 10-year behavioral health plan.
There used to be a stroke specific plan.
You know, I think I have this real fantasy that we have that would create a model of perfect communication where each one of us knows what everybody else is doing, what our, you know, what services we can provide, what services are available, all that kind of stuff. And I mean, it's probably a dream of fantasy, but at the same point.
Well, you're not the only one that has that dream, as you're gonna see in a few seconds. No, it's okay. You're good, you're doing good.
Unfortunately.
You read my report. Kim, go ahead.
Not sure where in the discussion this fits, but one of the things I'm concerned about is whatever measurements of data that are collected and used are not just numbers about how many people were enrolled and how many times did this client get to do that, but it has to be qualitative data. It's almost more important than quantitative data. And I feel like when we did the New Hampshire Lives Well, the ideas and dreams were for people to have a happiness factor in their life and a quality life. And we've seen for decades that if you're just looking at straight numbers and funding straight numbers, you miss all that. So you could be spending a lot of money on certain groups and they're still miserable and unhappy.
Right. Yeah, I mean, there's no.
That qualitative data has to have the same priorities the numbers have always had.
Yeah, and I think, again, going back to even just Bobby's point, it's like, we can say how many things that went in the chips that were in the ship, but it's also like, what was that even like? Was it useful? Did people, is that a process they even wanted? I mean, that's that kind of piece that's involved.
I think when we were looking at all the pieces, the broader perspective, we had to sift it down into statements that were true, that sort of gathered everybody's thoughts about what would improve life in New Hampshire for people. I thought from those very first stages, it was thought that the next steps would be filtering that down to the individual groups that were affected by whatever public health decisions were made in New Hampshire. So when the qualitative piece comes in, it's like for cancer patients, you know, they're having maybe more access, better coverage, whatever, but is it really doing what they need?
Right.
And that takes direct information from the people affected, not the agencies that serve.
Right. That's the difference.
I really appreciate the fact that we may spend so much time taking complex biopsychosocial metrics and trying to simplify it to one little number that doesn't. Quality of life, function of life, and it's not chapter mix.
Well, and I think, again, the thing that this group did well was it's the first plan I've ever seen at this level that talks about community and in that piece of being kind of connected, which is you never see it again. The old school way to do this was for public health to throw our little things together and put it in a binder, but you all did something much different. That's why we're here. So
I was excited because 95% of healthcare is not.
Right. If it did, it was going to be 15 minutes long and expensive.
That's why I'm excited.
And the one my buttons are working. Hello. So we did talk about work groups. We had, I think it's total 1, 2, 3, 4 different work groups last time. Not calling anybody out, it's all anonymous, but folks did say enjoyed having deeper discussions, kind of like what we're trying to do today. More time to actually share, again, specific. Kim brings in her focus, gets to talk to her piece. She's got an extra hour to do that. It's not all tons of time, but at the same token, with the ones that we had, people were pretty confused. It was just like, are we working on just the report? Didn't seem to be any real outcome that was, we just didn't do a very good job of saying this is why we're in the work group and this is what we're going to accomplish, other than the report, which was accomplished. And then people, when I asked folks like what would be better, what would make the work group better, folks were really we just want the topics to be specific. We want to have an outcome. Again, I think Dave's point about leadership, it's like a strong facilitator maybe just means having that strong direction, not just saying we're here to talk for an hour for no particular reason. And then the roles, as Dave mentioned, when my typo that wasn't a typo, they just wanted to know what they were doing there specifically for, what is my particular role here. So I think whatever we decide to do, and there's a little more information coming up, we have to make sure that those 4 things are there. Otherwise, you're just spending an hour more of your time, which you don't have, to not really feel that.
I've been a leader here for a very short period of time. But if I'm not doing a good job or I need to be different, well, let me know.
I think
but I do feel strongly in discussion. I just think that people learn a lot more.
I think it was just, my impression of it from talking to the 15 different people was just, if somebody can just give us a direction that makes sense to us and give us our rules and let us do our work, then that was fine. And for whatever reason, again, they felt like their job was the report and they did the report. And again, some of that's on me for not really, yeah.
If I may say, the last meeting that we attended for this restart was probably the best meeting I've ever been to, because it was really open conversations with people around the table. And I think that's where the direction comes from.
And I think, yes, you're right. And as long as you support group in a way,
Time to change everybody's name to something anonymous, yeah.
I can purchase this, these purchase things. Having support on a regular basis, and what am I doing wrong? What am I doing right? What can I do better? What are you doing?
Well, I do think that's an excellent point, and I would want, you all don't know me very well, but I would want that too. Like if after this meeting, you needed to say something to make this thing better, I would want you to do that.
I'll be quiet after this.
No?
But one of the things that we have seen repeatedly, and what is always the worrying factor, and one of the goals of this group is to provide information to legislators who are making decisions on subjects that they are not experts in. And so I think one of the things that we need to do going forward is maybe members bring to this group, I am really concerned about this. I'm worried about Medicaid, cost shifting down to the state level. We know the state's not going to have what it needs. So let's start working right now for the wave we know is coming in 2 years about if you're going to be cutting these programs, these are the ways that you can cut it without affecting the individual's quality of life.
And that is part of the job of this in the statute is to suggest legislation and also talk about that cost effectiveness and hello.
I just want to add to that because I was going to just clap.
You can.
From the department perspective, having that would be so helpful because I feel like a lot of times we end up being sent down to the State House or the LOB to be the people saying those, and to be able to actually engage partners. Like Scott and I always talk about, we were involved in an indoor tanning ban legislation. And that was it was beautiful because it wasn't the department. It was all the logical players coming together and providing rich testimony, as opposed to sometimes I won't put Ben on the spot, but sometimes we don't feel like we can do the things that partners can do down at the legislature. So
it seems like that's what the work group should be working on. And it's going to take 2 years to do that sort of work, to be able to provide
Yeah, the legislative work group was something that, you know, if there's 15 folks, at least 5 or 6 folks, and specifically, I think having a work group specifically kind of being active about legislation that's coming in, reaching out to folks that need to be, because one of the things about information that people brought up was we want to be able to bring our information in here, and that includes individuals, because we don't work with individuals, we work with people who work with people who work with individuals. So information sharing has got to go 2 ways. We've got to get the information from all of you and your partners. Then we've got to bring stuff in that you can share about.
So I will say, just a public member, but when you just described his one really discrete function backwards, or function partnership, and the zero authority whatsoever for it to looking at your partnership policy and education, just to get a feel for this being helpful to a good mechanism for helping educate, especially when it was the result, yes, interesting. So I'll say that what do you identify? Much more from a state perspective and also from a.
And I think.
So Scott, was the person that just spoke, because they were breaking up and going in and out, is there a way that you could reiterate what was just said or have the person repeat? And are they close to the mic?
She's in the gallery, so she's trying to yell, but yeah.
Oh.
Come a little
Do
closer.
you wanna describe again? Well, if you heard what I said, then I think this commission should be working in work groups on the issues so we can educate legislators who have to make decisions. That we provide that information to them, so that they're not kind of flailing in the wind and making poor decisions. So, I'm sorry, your name again? Bronwyn. Bronwyn just sort of agreed with that and said she spoke with a group of people, New Hampshire Policy and Education or something?
Yeah, so it's a New Hampshire Cancer Partnership. We just established a policy and education committee. And with no authority, I come to some of these meetings, like, boy, this would be a really great platform to amplify that and actually get education and get stuff before our legislators, before they're making decisions, because it feels like we're always chasing the decisions out. And so I floated, could we have a pipeline to the ship? And the policy and education members said, yes, absolutely, we'd be interested in that as a pathway. So I just wanted to endorse what she said.
Just so we know, I think there's like 1,200 bills already that have been filed or something. And some of them are really not.
Yeah.
And I think that was the one thing we talked about, was just being better, proactive and retroactive. And I think the legislative committee can help us do that.
Yeah, and I
But
think.
we really need to maybe put this on the agenda for next
Yep,
meeting.
yeah.
Because it starts in January.
Well, and I think we can even start, I mean, if it's, again, it's not me, but I'm just the helper, but if people are interested, we can even start kind of gathering some names.
Sure.
Be ready to put that in place when we talk to each other.
I'm even action plan already. Good job.
Isn't it crazy? Yeah. It's amazing.
People in the room can just identify themselves. When
Thank you. Is that right? Bronwyn Barnett is, I'll identify her as fantastic.
I have no technological expertise at all, but that thing's a microphone, right?
Yes.
Should we put it here with that?
I don't dare move it.
Yeah.
I'm sorry, I'm pretty good, but if I move it, the cable's kind of shaky.
I
So, yeah, we'll try to have people come a little closer from the gallery, just so everybody can. So again, just very quickly, I want, okay, sure.
If the ship council could do that and do that really well, that would be incredible and effective. At least more time, and the community would absolutely appreciate that.
Thank you. These were smarty.
So, not to be a downer, but I just wanted to put a little, when we asked about progress, I mean, I don't think this is telling tales out of school, so to speak. But I did we make any, that was kind of an interesting question. But then, one of my favorite quotes was, we each measure progress differently, but I think we know that we need to do a better job of making everybody feel in progress is that.
Anything else that was a continued support, I think that is. Make progress.
Yeah, I know you heard Justin, but Justin talking about we didn't have a forum for a long time. But I think
we're on 2 meetings in a row.
that's amazing.
So reach around, put your hand on. Yeah, this is awesome.
Yeah. But I also think too, not to beat the dead horse, but, yeah, we just didn't have a great set of plans to kind of fulfill it. So that was awesome. So when we asked about successes and challenges, I thought it was funny that both successes and challenges came from the broad SHIP domains. It's like, the good thing is like, we got this great plan. Anybody can fit underneath it. The challenge is we didn't have any real specific, like if it was all filled out, maybe we would have this thing we'd go do. Success was we have a SHIP. We solved the quorum issue, as David mentioned. You're all pretty dedicated folks. That's obvious. And then again, that opportunity to advise on a statewide level. But I think we've talked about the challenges already. The direction, the leadership. One person mentioned 35 different schedules, and I kind of high-five them virtually because it is hard to track you all down. But you do a great job getting back to me when I do. And then facilitation changes. Some people really did enjoy the way that Joe and Katie presented things. And then again, location. Some people mentioned we used to meet different places, and this was a different one. So just again, a lot of change. So 3 big things when we asked people what the most pressing public health issues were. Access to healthcare was, again, it's a very broad piece, but people were talking about that. Both the fact that we are an aging population in New Hampshire and then the affordable housing piece was, they were kind of a tie. And then that behavioral health piece was, so I don't think anything was really all that surprising. And again, including access to healthcare was EMS services, things that have been disappearing. So yeah, it wasn't anything terribly surprising there, but that's what you all kind of talked about being your 3 biggest state public health issues. And then again, when we asked what our priorities should be, not that it's not a plan for priorities, it's just what people thought. And then again, it goes back to coordination of care, basic needs such as housing, food, etc. And then really the last one was specific to us, better communication, better leadership. And I think we got that point pretty well loud and clear. So really the last piece is, these were the things we heard more than anything. Again, clear goals and directions. I think we got that. The information, much like what Kim was just talking about, and maybe Justin and Bronwyn, how do we make sure we're getting information from the community, from regional health, the networks, from individuals, that we're not just making decisions based even on what Kim said about an agency. And then how do we get information back out? Because people did say they like to have this group, as one of their big reasons is they can take whatever new information they have, they go back to the people that they represent, say this is what's going on. One of the things about sharing information was the Champions program that Joe and Katie were working on, the SHIP Champions. And how do we actually, or do we want to recognize some of the good work that's actually going on in the state and kind of put that SHIP brand on? So that's something that can be, and again, like Dave mentioned, either a community engagement group or a communications group, people could focus on that. I was in a group that did that, a governor's council group. People really loved having that recognition if they were doing something well, and then just being able to share what they're doing, which is something that Ed talks about all the time. I'm sure Bobby could reel off about 10 things right now that Nashua is doing really well. Maybe the rest of the state doesn't. So even just so people could emulate that, they don't really. And the other piece about information is, do we really want to, that's a little further. They want to advise, all of you folks want to advise. You're here to advise, you represent, you want to be able to actually have things that you're advising on. Be it legislation, be it what Whitney's going to talk about in a few seconds, something that DHS is in charge of. You all want to be able to come here and provide your expertise and your thoughts.
But that might be another separate work group, but for Ed, a roadshow is like really important.
Yeah.
To take this live and do it in different communities and learn from them directly. And it was develop tentacles that way.
Yeah.
And I know, like, excuse me for using this as an example, but when we created the opioid policy in 1997, we had basically what we created is what the CDC uses now. So it's not, nothing's changed. The thing that we did not do that we wanted to do that could have made that dramatically better was to go on the road, which we, and yet tell people, this is what the policy is, this is why the policy is this, and this is why you need to follow it.
Yeah.
We never did that.
Right.
And look what happened.
Yeah.
So those outreach things are really important, and maybe that is a more current
Yeah.
thing.
I think one of the things that, and this goes on to the next one is, this is the problem that I had with it. I really like I'd like to hear what people think. When I first saw the ship and I talked to Ed about it, I was like, I don't know what I would tell people about it. Like, it's because it's so broad. It's like, I know that these broad things, but there's nothing really specific in it. And it was interesting talking to a few people that during those interviews, and they're like, we're doing it backwards. We shouldn't be going out to talk to them about what's in the ship. We should be going out to find where they fit and what they're doing and have that be something, because I can't tell you how many times I've been asked in 22 years, I don't know what's going on in the state. I don't know who's doing what with food. I don't know who's doing what with EMS. I don't know who's, although I can also go to Justice EMS, that's bad. But I just don't know. So if, again, their thought was maybe this group, through we work group or through the group itself, can use the ship to kind of fill things in where what's actually happening, and you can see where the resources are and where they're not, and where things are actually happening. And I thought it was genius, because I don't think going out and just talking to people about this big ship would be anything that I would be interested in if I wasn't part of the group. I'd want people to ask me how I feel what I'm doing. That's something.
I'm the designated pointer to you and do this.
Please do, because I'm.
No,
Check about this and point out how the priorities will be, what's important to you to implement these. And I feel like that's a big gap between saying, here's what you know, and then here's what how can we actually make a change. And so I feel like there's a support question that needs to be made in this conversation. If there's a roadshow or it's really hard.
and I get that totally, because as a practitioner, like, I deal a lot with addiction as a side effect or whatever. Where do I send this person? And I don't know. And, getting somebody to tell me, well, how do I deal with this? Where do I send? Right, to be perfect knowledge isn't perfect.
I just wanted to build on that comment of, I'm thinking back after the control site, but like you had this slide about suggested priorities and like housing being one of them and improving access to coordination of care. And I think that's exactly right, Bronwyn, of like, if you bring out and you start to have conversations about like, what are you doing around improving access and coordinating care, and then what's getting in the way? And like, I know in the cancer world, like the cancer, people who are working to support cancer survivors are like, one of the things that gets in the way is I don't have a tool to go to know all the programs and services available to connect my survivors with. And so that, like, I like that idea of like, under those big umbrellas of like, these are things we want to see change.
Yeah,
Let's get
where's the bridge for? And that's on a person specific or a client specific, but also on the organizational level, right? Like you are telling me I should be doing something like that bridge.
Well, I think that cancer is a good example too, because I always, when I talk to folks with, kind of survivorship is not even a term that everybody likes, but you got these small hospitals that really only have 2 or 3 programs to offer. And they're really kind of supposed to keep the people there because they're, programs are, they're bringing insurance money. But they also want to be able to offer, I mean, one of those 3 programs isn't what you want. That's all they have to offer. So are there things across the state, even because there's so many online programs, you don't have to be in a physical location. Good.
Isn't that what the function of 211 is supposed to be?
To me, it's like a combination, right? Because you have 211, and then now we've got sort of Unite Us, which is supposed to be, yeah, I know. I think this is the official Unite Us gesture. It's like, so it's like, yeah, we have a couple different things that should be that, and like maybe it's about marrying them or like what's not functioning right now, which is gonna tie to my presentation.
Yes.
Your segue. We have that same problem with the Seacoast, and sometimes we have to go way up to northern New Hampshire to get some programs or some treatment that's not available this fall. So locally, we have CRN, the Community Resource Network, started by one woman in Portsmouth years ago. She works for Families First. But it's a website, and you go to it and you just say, I need cancer support, and whoever's registered in it, it's not just open to the public, but it just pulls that up, or you say I have elders or housing or whatever. And works really well for us in our small seacoast region. So we did that because 211 was so far off the rails.
Yeah.
So,
Yeah.
Sorry.
But that's like that's a great input into the like, yeah, so 211 didn't meet that need, we did this, that might be innovation that we want to then, share and replicate. Or maybe we identified, improvements to the statewide option.
So, Maria Boylan, I'm a representative for the New Hampshire Medical Society, but I'm also a family practice doctor and the medical director of Primary Care Health Hospital. I would say that there is such a disconnect with primary care providers and the knowledge of what's available all throughout the state in terms of programs and resources for patients. To the point where like sometimes I'm in the room just Googling for a patient to find like, what can I do for them?
In your 15 minutes that you have.
Exactly, yeah, and
Ditto. I have to agree with you on that. From a provider standpoint, you feel very lost in connecting individuals to the sources or even knowing what's out there.
Thank you.
I mean, a very fast backwards way of doing things. I read for office and I heard of things. But I wish I don't practice it. And that's kind of what motivated me to suggest that this group serve that purpose.
I think, Justin, I think one of the issues though, that we're missing, to your point, your 201 is that pathway to provide helping where the resources are. I don't think that, from a public perspective, people know what the problems are, right? Like, here's resources. Well, we don't get resources because that's not a problem, right? And so maybe it's the education to, these are the problems that are going on. The issues we have for, housing and food, and maybe maybe a priority of the council should be that education piece, because we're a group of state entities, non-state entities, public members, so collectively as a voice, saying that these are the problems, not just solutions to what people are. Prime example would be EMS side of the house, but as the LED units are closing down, and the more pre-hospital deliveries, we're have a huge focus thanks to DHHS for money and access to resources, but we're providing more education for our EMS providers on be in that relevant training. Great, here's the solution to a problem, but here's the problem that LEDs are closing down. The real problem is that in New Hampshire, in the top 5, I think at number 5 for maternal death, right? And so, that's a problem. So the solution is to provide education to folks that are seeing these problems sooner than anybody else to avoid that from happening. So I think that education is huge. And sorry for the soapbox, but also having a group that legislatively is charged with being the subject matter experts in all of our disciplines.
Bigger point to me is, besides the education, are our solutions matching the problems? Want to have you go first, second, third?
Comment on the.
Oh, okay.
But there could be an opportunity to look at the various plans mentioned earlier, so like cancer plans.
Right.
Behavioral health plans, to identify priorities that other plans have already identified. I think kind of to Justin's point too.
so, and you kind of touched upon this earlier, but I think this really needs to be a two-way street, not only us like going out to the communities and educating, but also finding what are other groups or health systems or practices doing really well that we can learn from. So, for example, 2 years ago, we were told, okay, we're really bad at lead screening our kids in the state. Like we dropped to like under 60%, especially during COVID. So we recognized that at Elliott, that's a big problem. We needed a huge lead screening work group where we took our numbers up to 92% in the course of the year. And so, but then I'm like, well, why? We should be teaching people how we did this and how we did it well. We should bring that back to the state and say, hey, look it up. Our numbers for 1 and 2 year olds are 90% now. So let's tell you what we did well that you can give to other people.
Ed's not here, but he would be very proud of you for saying that. How do you highlight the things that are replicable? Yeah. Where-
Well, to that point, I think that's exactly what the role of the work group should be, because if you have like-minded people working on one issue, you're gonna get much further than 35 people.
It's not.
So I think that's really important. But the other concern I have is it takes time for these work groups to get together and to really drill down into an issue and talk to the appropriate parties, which are often the patients.
Right.
Or clients, whatever you want to say. And right now, there's money in New Hampshire that's going to go away in 2 years at the next budget session for support and recovery housing. There's $10 million. We're having a hard time finding a program that has done it well to invite as sort of the introduction into our community. You know, we should support these programs because they can be successful. They can do well. They can be not disruptive if they're done correctly. But that money goes away in 2 years. And then we have the opioid settlement funds, which now United Way is giving out grants on those that are substantial for, you know, yearly operational costs and things like that. And so right now is the time we should be working on this and get something together so that we can take advantage of the funding that is available now.
That's important. That was the entire discussion.
So I think that it's interesting, the last one that we didn't get to was action, and I think you're all talking about a lot of action. I'd like to give the folks at homes and offices a chance to either put in some chat stuff or really just to come unmuted if there's any additional thoughts on this. We've dropped a bunch of slides on you about a bunch of information, but this is our time before, you know, Whitney will take us on to the next reward for us to be able to kind of provide any input.
Hearing none, can I ask?
Go ahead.
So I'm just writing down detention groups. I'm just curious, like you're talking to about item specific work groups, which makes a lot of sense to me. Most of what I'm writing down is just stuff like detention. Is that something you think that we should be working at, is identifying problems and developing as a group specific to that?
Well, because I'm a boots on the ground health officer, I interact with people who have the issues, and so I work backwards. So I'm more of I understand what this person's coming from, what the issues are, why they're always in this turmoil. And that leads into communication and resources and people who do it correctly. And so I'm less of a global thinker on solving these problems. So I would be comfortable working on groups that say, you know, the IDP population, how are they faring? Homeless population, which I'm not an expert in, but I have real concerns about, you know, or the recovery housing. So I'm thinking really specific population for me. I'm not great about communication. Clearly.
The reason I bring up the question is like, I got a list now, probably. And that's just not doing 35 people, but, you know, where do we want to focus our energies and things like that?
Yeah.
I mean, that's something we can talk more about as we go on, but you said very specific at the time.
Yeah, and I think one of the things I would suggest would be, you know, when I get the notes out to you, to try to put some work group suggestions out there so we could start at these collectives.
Is this recording? Because there's some good chat stuff.
It is recording and we have the transcription. Yeah.
Can I ask another question? Is that on our website?
So while Whitney's coming out, it's actually kind of a fascinating thing. If you go to this, some of you may have gone to this, they call it the GenCourt website. It's probably from 1982 or so, as Megan's nodding. You cannot put recordings on that website. You can put documents, and even that's not great. So what I'm trying to do now, and I'm hoping in the next week or so, we'll have on our website where you can get the actual recordings.
That's what I was thinking, so they could go to our website.
Yeah.
Because I did get to it by accident. I just went to New Hampshire State Health Assessment Improvement Plan. I just Googled it, it took me right to this.
Yeah, so I think that's That's my next chore after meeting minutes and getting those things out, is to actually find a place to put that recording. So, because it'll be a large file size to just send, so.
I will have it inspired by law.
That's a really good question, and not in the legislature, so.
Having the minutes in the agenda.
Yeah, so we do put the minutes and any documents on the agenda.
You generate, I'm assuming you generate the minutes from the report.
We will now. I don't know how they did it before, but there's probably.
So I mean, there'll be minutes.
Yeah. All right, well, I'll turn it over. I think this is actually a lovely segue of being able to actually talk about things that are going on and provide your expertise.
Okay, cool. I'm just gonna check, how much time do I have till 2:15?
Yes, you do. So you go.
I bought it in 10 minutes early.
You did.
All right, are we really ready?
We're good.
All right, so I moved up here because I saw in the chat, that it was sometimes hard to hear people.
Yeah.
So I threw together these slides so fast that they're not complete. So I'm gonna try and actually fill in the blanks, just with this cover page up. So, I don't know if everybody's heard about the Rural Health Transformation Program. If you haven't, congratulations, I envy you. So, yeah. So the gist of this, for anybody who's not familiar with it, is that back in June, when they were trying to come up with and get past the One Big Beautiful Bill, or HR1, there was a sort of last minute deal made to get the votes through in time to have a July 4th release of the Big Beautiful Bill, that authorized $50 billion to be allocated to states to address rural health transformation. A lot of the impetus for that was concern around the impact that Medicaid cuts that were included in the One Big Beautiful Bill. So things like work requirements, every 6-month certifications, and other mechanisms that are articulated in that One Big Beautiful Bill would then lead to financial hardship for the small rural hospitals in the country. And so there was this $50 billion allocated with very rigid timelines that feel almost intentionally like put on us to be failing. So really like gave truncated timelines for the feds to put out the notice of funding opportunity for this, and then really truncated states' timelines to pull together applications for this. The dollar amount, and I have to be honest, like I work in the millions of dollars usually, and so my brain is struggling to even put the right number of zeros on this. But for quick math, we are being told to, every single state, so all 50 states are being told to submit applications that will be for $200 million per year for the next 5 years. And just to give context, because again, that number of zeros and millions is like kind of beyond my comprehension. Our Division of Public Health Services has an annual budget of $134 million. So this would be 70 million more per year than what we get for all of public health. The grant is a CMS grant, but the way that New Hampshire is approaching the application, it's a really close partnership between public health and Medicaid, and then a number of others, including the Bureau of Emergency Medical Services, so Justin's been involved. But so that just gives you like a little bit, and let me tell you timeline. So the NOFO dropped in the beginning of September. That's our notice of funding opportunity. So we sort of all just sat anxiously from July 4th until that dropped, and we had some guesses about what would be in there based off of the language in the legislation. It dropped at the beginning of September, which started the clock on a 6-week period for the department to pull together our application. The department has done stakeholder engagement prior to that NOFO dropping, so people have just proactively reached out to us and offered suggestions around ways to use the funds. There was a survey of all hospitals conducted by the New Hampshire Hospital Association. The governor held a summit in the North Country and invited a number of key stakeholders to come together and have conversation about what would be useful to put into our application. After the NOFA was posted, the governor also requested that we open a request for information or an RFI. So the department did create a website, and there's an entire Survey Monkey that anybody is invited to submit and they should have ideas into. At the same time, a team of people have been assembled within the department. We've identified subject matter experts in certain areas where we anticipate having initiatives. And those subject matter experts are right now working to engage with partners across the state to get more and more information. This is like an unprecedented turnaround time. We are very fortunate that the Charitable Foundation, the New Hampshire Charitable Foundation, was able to provide funding to secure a grant writer for the application. So we are contracting for a grant writer who will do a lot of the synthesizing and getting it to the finish line. But really between now and October 10th is the planning. We're kind of taking an approach. Oh, let me share one other thing. The funding on this is going to be really wild and crazy, and that there's a big emphasis that if you don't spend your full award amount in year one, which if anybody's been around, we struggle to get money out. We first have to accept it into our budget, then we have to actually execute contracts and get it out of our budget. And I'm looking at Ben because he went through this recently for a contract. It's like, it can be a year-long process to actually free money from the department. If you don't spend the full amount that you were awarded in year one, they will redistribute what was unspent to other states that have demonstrated success. So what the department is trying to wrestle with right now is how do we pick some what we're calling shovel-ready projects that have been identified, by different partners throughout the state to put in for the first year, while then also building up a much more like intentional strategy for, full transformation within the 5-year period. That's the like high level overview.
I have one question.
Yeah.
What's required for the submission? Is it just the first year or is it full 5-year strategy?
It's the full 5-year, but this is what's called a cooperative agreement, which means that it's intended to be a very sort of collaborative relationship with the feds, and there's ongoing ability to be revising what we submitted. And there's always the expectation that your actual budget will be revised year to year. So that's where I'm telling people who are kind of struggling with this, I'm like, just get it as close to like good, and then we'll submit it and we'll clean it up on the back end.
And then the second question was, do you have preliminary results from like the hospital survey? North Country meeting that happened? Is that something that you're planning on?
Yeah, I didn't have time to synthesize all of that for this presentation. The next slide that I'm going to show is at least like, and it's drafty draft. It's me trying to visualize like what is our framework in New Hampshire, and that is based on synthesis across those different inputs. And then I thought you were going to ask me about data. So we rapidly have our So we're using our public health team, and they're looking at population level data by rural, non-rural. I should also add, New Hampshire is almost entirely rural according to the definition for this grant. So that you kind of have to like, I'm looking at Kim, like Dover is part rural according to this grant. Yes, exactly. So it's pretty largely New Hampshire. But I did want to just, before I go to Dave, so the public health team is looking at our data sets by rural, non-rural to start to do data driven, like develop what is going to change as a result of the 5-year grant. And then our Medicaid team is similarly looking at their data and our claims data as state to try and also think through our strategy.
I guess, I had 2 questions also, but you kind of answered the one already. We're a giant rural state.
Yeah.
I understand the concept of going to the North Country, but Massachusetts border, the Vermont border, those are incredibly big. It seem to always get forgotten.
Yeah.
And they have a lot of the same issues there.
Yes, yeah, so those are not forgotten in terms of the definition of the state of New Hampshire. I'm already having conversations, like big high level dream ones about collaboration with Maine and with Vermont in terms of being able to. So a lot of the feedback, and I'll get into this a little more later, but any of the providers in the room will probably nod your heads at this. We for years have gotten feedback that if we're going to change clinical care delivery, it's going to have to be a payer agnostic approach because providers just cannot do care differently based on who your insurance is. Like nobody wants to do that. Everybody wants you to get the right care regardless of the payer. And so there's definitely interest and emphasis on like, how do we do this cross payer? It's interesting if you think about New Hampshire, Medicaid's not a big payer in rural, like in other states. Medicare and commercial are actually the like market share in those rural areas. And so we are talking about how do we engage with them as well.
Yeah, because that's a big learning experience for me over the last 3 years is you can't exclude them from the discussion.
Yeah.
And I'll be honest, what we found out with our prior authorization legislation is they have the same concerns we do.
Yeah.
And so you may find out that this is a big deal for them too. But like, how do you make it more uniform between payers so that we don't have to know? That's a big issue for them too.
Correct. And also like so I'm saying it, like the ideal state is payer agnostic and state residency agnostic. So that if you have a Vermont resident who you're giving care like up in Littleton or Woodsville or at Cottage Hospital, like you don't have to sit and think like, wait, are they from Vermont or New Hampshire? And then what's their payer? Did I see a hand over here?
Well, are you talking only about providers? Are you talking about like public health nurses that go out into the community? Are you talking about prevention programs such as like the Vermont used to have an agricultural medicine through the cooperative extension?
Yeah.
They would just go out and teach preventive services because so many people get killed by, tractor rollovers and stuff. I mean, it was really good education, but is that all included?
Yes, it's all included. I'm looking at this. This is my it's too small. I'm wondering if there's anything I can do to zoom in. Let's see. I'll just talk people through this. So while we were talking earlier, I just put in highlighters. So the words at the top of this are the different things that we're hoping to see impacted by the grant. And I had to highlight for Kim that quality of life is actually already on our list. So we have a lot of the like access and utilization stuff. Are people getting their preventive care visits? Is primary care utilization like a higher ratio of care than like inpatient? Specialist access, transportation related delays, emergency and hospital-based care. Then we'll look at health outcomes. I don't think in 5 years we're going to move the needle on length of life, but if you've ever looked at the department's website, the life expectancy in northern New Hampshire is like 6 years less than the rest of the state. So that is like a long-term goal of this transformation. But then I think very importantly, quality of life. One thing I really like about this NOFO, despite the fact that it went real fast, is there's a huge emphasis on program evaluation. And I see that like qualitative data as a part of the program evaluation. And there's also not just evaluation, but stakeholder engagement, which I have a slide on later. And they really do specifically say from like, like folks like us, like, professionally engaged in this, but also at the community level, the people we're trying to actually impact with this. So the way that this is, we're kind of envisioning it, I'll start from the bottom of the house. Those are the sort of foundational strategies that we think we're going to include in the grant application. Use of technological innovation is going to be like thread throughout this whole thing. That's technology at like the provider level. So I'm learning all sorts of new stuff. I didn't know about ambient AI and the fact that providers use ambient AI in their encounters. Looks like Dave, maybe that's something that will like.
Let's say,
And then so it includes those provider tools. It includes a major emphasis on like interoperability of different systems, maybe enabling folks that don't have EHRs already to get on EHRs. There's technology, like we're talking with Justin about how is EMS going to actually be equipped to then to go out to a home and facilitate a telehealth visit, and that they'll need the actual like tech tools, but also the technology to be facilitating that. The second thing in the foundation is just growing the workforce. And this is everything from, we're having conversations about how do you get middle schoolers and high schoolers interested and into the pipeline for workforce? How do you how do you pay for schooling so that people don't even need to have that cost in the first place? How do you pay for loan repayment if people come with loans, but you want to recruit them and retain them? All the way to, we heard a really innovative idea yesterday at the Primary Care Legislative Commission of how do we leverage our older adult population in New Hampshire as care providers and like actually making like an on-ramp to the pipeline in like a more retirement age if you wanted to do mobile integrated health, because I know a lot of EMS professionals, it's a very physical job and maybe you hit a certain age and you're like, I cannot do the stretcher, but like I would still love to be out there in the community. So creating on-ramps, because again, we know our population is older in New Hampshire.
There's a question from Martha about have New Hampshire counties been contacted for ideas?
Counties haven't. I'd love to think about how to do that because I've been scratching my head about where's the county's role in this. Up in COAS, the county was invited to the summit, and that's where we got some input around the need to engage around long-term care and county-based long-term care.
And being sure that
The New Hampshire Association, sorry, I have a cold. The New Hampshire Association of Counties, I think, is meeting on October 3rd. I know that's maybe too far off. I know you're working quickly. But you may want to contact Kate Horgan from that group and see about presenting and talking to that group. I know they'll have lots of ideas. In Grafton County, we're working on EMS services as our small towns are dropping like flies with their EMS services. So I don't know how that would be included in this, but they're coming to the county and asking how we can help them set up some of these regional services. And so that's just one thought, but
that's that
awesome.
Would be I wrote it down. I'll reach out to Kate because within October 3rd is well within our time period. So,
I'm just curious, like how it doesn't sound like we're competing with other states, and that do we have the ability to communicate with other states for ideas on how to do this? And the only reason I bring it back, I mean, I work for the Indian Health Service and all that good. I'll be honest, you don't get more room.
Yeah.
No.
And they have some great models for providing all this care that we can borrow from. And I've been seeing that forever, but I'm just curious how much we can do that in this time frame.
We can do that in this time frame. It is competitive to a certain degree, but I'm not concerned about communication with other states. Half of the money, so 100 million, is just if you successfully hit submit and it's a technically fine application. The second half so the other 100 million is going to be based off of a number of different factors. Some are out of our control. So that involves what's your population in rural, what's the square footage of your state. We're going to score low on those. Do you have frontier? No. So we're going to get low on that. Percent of population in rural, we're actually going to get high because we're almost all in rural in New Hampshire. Then there's this whole other component of our competitive scoring that's really different. And I'm actually starting to like it, but ask me in 5 years and I may hate it. There's scoring based on policies that we have in place and our commitment to implement certain policies over the 5 years. And I was like thinking, as Kim was talking, like there could be a role for the council around those specific policies. So one, for example, is states that have what's called a SNAP waiver for non-nutritious foods get $100 million over the period if you just have a non-nutritious SNAP waiver. And what that is for people that aren't super familiar is essentially that you don't allow soda or candy to be purchased with a SNAP benefit. There are some other policies around scope of practice for different provider types, and also licensure compact, is that the term for like allowing practice between states? So there's some healthcare delivery policies, there's some like food and nutrition policies. And then the other third of the competitive scoring is the quality of the initiatives that we submit. So that's probably the only place where state to state, there's a little bit of competition.
They define rural by area or by population?
They define it using the Federal Office of Rural Health. It's within HRSA. They have a definition that they, big surprise, updated the like day after the NOFO was released. And that is based off of like many different factors. One that's like newer to the definition and it's beneficial to New Hampshire is something called road ruggedness. So it factors in that, like, if you've ever done that thing where you look at this is going to date me for how old I am. Like when you used to have an atlas in your car and you'd like eyeball and you're like, okay, that's the distance. But then all of a sudden you're driving and you're like, okay, first off, the road doesn't go straight there and there's a giant mountain. So
It's a map. I know. I get it every year.
Well, so yeah, fun story. I fought my husband on an atlas in the car. We went to Chicago and got stuck underground and the GPS stopped and he was like, I told you. So now we have atlases. So
Ask a clarifying question too, because I heard Dr. Ballard's talk on this earlier this week. And it's my understanding that like the funding also can't just directly go to like, well, let's just pay for nurses and primary care providers and that, like, you can't just pay like loan forgiveness or salaries of like the people that you, right?
So there's a little, this is like where I think our bureaucratic finesse will come in. So it's like when you read the NOFO, it might seem like technically you can't do certain things, but I think we're going to work on our side. So one example is that there's a cap on how much can go to direct care, but there's within that, it's anything that's not customarily covered by direct care. So for example, like if we wanted to reimburse for CHWs, well, we don't really have a mechanism right now. And so, yeah, that would fit in the category of direct care, but it's not currently reimbursable. Thank you. So just to kind of, so the two squares are really what I'm thinking of as like the way we're describing our initiatives. They're really small to read. So the way it came out in the NOFO, the dark blue one was essentially framed as make rural America healthy again. We're kind of reframing it in New Hampshire to strengthen prevention. So to answer the question of like, we're talking all the way upstream prevention, like everything like housing, transportation, food security.
You might not want anything that says make blank blank, yeah.
Yeah. Yeah, we're like playing around with it. That, again, this is very drafty, but so strengthen prevention and primary care. Somebody called this out earlier today. When we're saying primary care, we're talking like behavioral health, substance use, primary care, like in a clinical environment. Yeah, exactly. And it's interesting the way it's kind of shaking out in New Hampshire. It seems like that's where the interest and the willingness is. And we'll see where like the hospital related stuff really like fits in.
So just to clarify, when you talk about primary care, specify primary care setting or primary care services?
We define.
We define it as. Okay.
Yeah. And so we're like envisioning this as like,
broad.
Yeah, broad and inclusive. The other big bucket is ready access to health and transportation. It's an interesting one. Justin could probably like fill this in. Like, I like it because we're not necessarily, we could, but we're not necessarily saying like everybody's going to get a car. I mean, that's probably not a good sustainable one, but we're talking about like EMS is a transportation strategy. And so strengthening the EMS system, whether it's that they bring care to the home or that you guys like transport between facilities.
Yeah, I mean, the was to think, but I mean, ultimately EMS is going to be as a transport agency, especially to feds, and so I'm happy that it's included in this based on that. I mean, obviously we've gotten away from it quite a bit and are truly data-driven, well-prepared submissions that we finesse, but you know, it's related to mobile integrated healthcare. And it's focused on that, and which you know falls right in line with prevention. And then you know also helps out. I appreciate somebody online mentioning EMS other than myself in this case, but you know it's going to help smaller services that don't traditionally have the staffing want to perform with integrated healthcare, but also to have staffing to respond to calls, but providing this service and having the funding to implement it, and now you have staffing that can support the community and you know integrated healthcare, but also you know it's a foot in the door for providing perceptive coverage for non-enemy stuff. So I mean, I think, and then our other submissions for workforce, which only helps because now we have a workforce that eventually can get to whether they're old plus being burnt out like myself, or they just want a different, you know, change of pace from traditional and the one I that's what I think. So, but yeah, long answer to this.
And then the top or the roof of the house that we're envisioning is, and this is really the answer to the question of how do we make these things sustainable after the 5-year project period. This won't do it alone, but there's a lot of conversation around high value payment models. And again, we're just sort of starting down that path of like, what's the right one in New Hampshire? Is it all payer? Is it, you know, is it an ACO model? You know, but the one thing I think we can clearly say is that the savings from whatever high value model are captured, we're thinking need to be reinvested down into prevention and primary care. So that's like we're honing in on that as our payment model. That's the house.
Yeah, I think you might just address my other question because it seemed like there was a giant cliff at the end of this thing.
Yeah.
And I'm glad you're already anticipating that.
Yep, every initiative that's submitted is scored partially on sustainability after the end of the program funding. I'm learning a lot about Medicaid. They're always like, you can't just go and then poof, Medicaid will reimburse because Medicaid just has a certain pot of money and it's not going to grow. So that's where we're like really having to think creatively about, you know, how do we leverage commercial and Medicare, and is there other, you know, revenue that we might need to like tap into and suggest. I'm looking at Scott because he has a super secret project he did years back for Harvard. I think we talked about in a prior meeting where we modeled out the revenue that would be generated from a sugar sweetened beverage excise tax. Which is like another, so again, like we could be talking about that for revenue.
I actually was going to submit that bill, and after discussing it, decided.
Well, there you go. So,
But no, we need to keep talking.
yeah,
about that.
and it could be tied into this transformation.
Yeah, because that was what we were talking about.
That's one more example of how this commission could help with the policy.
Right.
Yeah.
You that you're talking.
So you just did a perfect segue, and I swear I didn't prime Kim before the meeting. So the most exciting thing, well, no, it's all exciting. One really exciting part of this is that we need to write in how, as a state, we're gonna have stakeholder engagement throughout the 5-year plan. I have to say, this has been like a sprint, and there was a piece of me that when this started, I did wish that we had that version of the ship that we just talked about today, where I was like, why don't we have it all written down together? Because then I would be like, you and you. So it's been like a little more just chaotic. But I think it's part of the vision that you guys all were talking about today and that was captured from Scott's work makes a place for the SHIP Council to be an answer to some of the question about how do we have oversight of the use of these funds. So this is straight out of the NOFO that we have to provide an engagement framework that specifies how we're going to have a formal process to engage stakeholders on a regular basis, which kind of, I almost could see Bronwyn's idea of like, you know, we have a process where we say, this is a priority, what are you doing? And we, you know, standardize that process. And so such as through a stakeholder advisory committee, that could be this group potentially, that has regular work groups and open door forums for feedback. These meetings are open to the public. So that's another like potential good fit. Another thing we have to do is describe how you'll ensure that the project governance reflects the communities you're engaging, including patients as well as providers. So that's again, like through our actual membership, but also the membership's ability to pull in others, I think, to give us input. And then this feels really well aligned too. So in our engagement framework, we need to address how we'll coordinate regularly with state agencies and partners around deploying funds, tracking milestones, and assessing impact metrics through a new or existing council. So to me, that's like the SHA. And this is an existing council, and we could actually be really like, you know, keeping an eye on what's the impact of this program. Yeah, well, and that was a big takeaway from Scott's work interviewing people, was like, use this to advise, like, we want to help give input, like, what can we advise on? And I'm like, I might have something.
This is like, I don't know, this is something for us to think about, but like, I did this with the Opioid Abatement Commission, is we have this nebulous set of, you know, agreements of where we can use the money. Well, how are we going to define where it's going to go? And it was just kind of like we're just shooting in the dark. So we just put together a subcommittee and we define everything. And if you were on our website, there's a priority to rate items that this is where the money's going to go to, you know, out of an infinite number. And it may be that may be helpful for, I mean, that subcommittee only met twice. So it's not like it's a long standing one, but like, you know, think about that in to help prioritize what's important for us. And if I can say one other thing, I'm sorry about, we need to really seriously understand what rural environments expect, what's reasonable. You know, they're not expecting to have like open heart surgery in some small little hospital, but they want to have really good primary care in the United States. You know, and access to primary care, the social determinants of health, things like that. How do they get the food, their education, things like that. That stuff's all reasonable. 70% of my patients live in far rural environments, and they won't mind driving to Concord to see me for a specialized thing. But for something like that, they don't want to Concord for emergency services. And I just think
for an illness or
well, even like point of service option, like poor Scott and I have worked together for so long. Every year when I have to get my labs, he listens to me complain about the fact that I have to go someplace else to get my labs because reimbursement, like, so. And I'm like, just to do the labs on the spot because you're going to lose me. But so like, that was something we heard back from one of the FQHCs up in COAS was the more things we can do in one visit, the less trips our people have to make. So like enable us to do the like highest value visit in one shot. So whether it's eyes, you know, the retinal scans or A1C testing. Yeah.
Well, I know that there's a strict timeline on this, but it is amazing to talk to people who work in the northern part of the state, brilliant people that fix it all, you know, under one umbrella. And so I don't know how many meetings this commission is going to have, but if they could be set, like if one could be set up in the North Country, and then your health officers that work throughout the towns up there could come because they might have input, and then the practitioners, clinicians, social workers, welfare directors, and it'd just be so much easier for input. And sometimes person-to-person input is just so much clearer than when we have to do things at a distance. So that would be a suggestion if we could do that. And when you're talking about behavioral health, and we heard that intellectual and developmentally disabled people and I think older people are kind of left out of some of the things. Does behavioral health include IDD? Does it include dementia? recipients, you know.
It does in my mind, but I think that we need to really like continue to, like, I think that that is a focus that has not, like, just by the nature of who's involved at the department level, I think we need to identify who, like, the agency that needs to be tapped for that. Cause like conversations come up at the very least about area agencies as like a piece of the puzzle. I also can say, because I pulled the data for the governor's summit, and it really, I mean, not surprising to lots of people, but the percent of people in Coos County that have a disability is considerably higher than the rest of the state, as well as the, you know, older population. So like, we would be really out of like alignment with the data if we don't consider both those populations.
Yeah, I would chime in on this. It's, we tend to get folded in by assumption for IDD into mental health. And they've got so many lawsuits, so much money coming. They do the substance abuse. So all of a sudden we're like a forgotten stepchild. So it would be great if we can just keep us on the table.
Like, is there, like, what part, I used to work over at behavioral health, and then there was the developmental services. Who would you, or is there a group in the community that you recommend?
Well, most regions have a parents group, so they directly represent the clients.
Okay.
And the people who have to care for the clients or care for clients. That's really where you get your information from, not the area agencies.
Right.
They have, certainly have a role, but that's the kind of quality life data that I'm talking about.
Okay.
Right.
Awesome.
The family support councils statewide.
Yeah, and I guess I was already starting to think about, it's great that this group exists independent of this grant application, because to the point that we need to be like ready and hitting the ground and spending money January 1st, 2026. Maybe there can be work between now and then with this group to like get, even after we submit the grant, because we're gonna have to start doing the work before it actually gets funded. So that would be great to do. And then ongo, like, again, how do we then continue to help with that engagement?
I think the Medicaid cutbacks are gonna affect that group of people more than anybody else can for their lifespan. And so it worries me that there's a cliff coming at the end of this, but maybe we can look at ways, we just need to make sure that persons with intellectual and developmental disabilities are in that behavioral health piece or other care piece, but they cannot be.
Yeah, them and their parent. One of my biggest concerns with all of this big, beautiful, whatever they're telling us it is that I've got a lot of families. It's the parents, the caretakers that are going to be impacted by their Medicaid being either shut off or, you know, the individual might keep trucking along because of the disability, but it's their caregivers that are going to lose out on a lot of things. And they hold it together. The other ones.
Yeah, caregivers are the ones that keep them from having to go someplace else.
But it's also the next view of your nursing home residents.
Yeah.
And so they're not gonna fit, the people that I know and that I'm related to aren't gonna fit well into nursing homes. And so there needs to be models and work done. How do we provide them with a quality senior life with all the other things that come with getting old?
So how are we on time?
You got a couple minutes? Yeah.
Okay.
And we built in some time at the end for fit.
Yeah, I mean, we're starting to have these conversations, so I think, you know, I can run through these. I wanted people to think, how can the state health assessment, the state health improvement plan, and this council be engaged in the program? I think we've had some good ideas already. Another one was, what should we consider in terms of initiatives? So we've talked a little bit about that and populations to be thoughtful about. The other thing, if people are feeling like, whoa, this is a lot and I need to think about this. There is this RFI opportunity. So all, like any of you all that have specific ideas can, Scott sent out the link already to the members for that RFI. If you want to reach out to me and like just actually have more of a conversation about ideas that you have, I am largely clearing my schedule for the next couple of weeks so that I am available. Because I know it can sometimes be hard to just interact with a survey to share an idea like this. So me and then a number of other subject matter experts are available to just connect with. If you have like that's not like a super secret link. So if you have like other groups that you work with that you think might have initiatives, we would encourage you to share that RFI link or my contact information with them.
That's a good point, because it did come up. It's like, is this link for us, or can we share it? Can we
Yeah.
share?
Yeah, it's open to the public. We want to cast a really wide net. And then I think like the other thing that I'm telling people is like, don't feel like just because you didn't get something in by this, like October 10th is our deadline for getting initiatives like ready to submit. This is going to be an ongoing, like, process of like modifying and like, iterating as we go. So don't feel like just because you couldn't pull together some $1 million idea on really short notice that that's off the table. Because I think, that's going to be the intent behind this, is to continue to get engagement and input.
And I don't know why your slides aren't advancing. My computer is completely frozen. I apologize for the state laptop here that seems to be checking out of the meeting before the rest of us, but
Yeah.
so I can't read the chat. I can't move anything, but I think unfortunately we're near the end.
Yeah, I mean, I think that's the gist of, I don't know if anybody, any other questions or thoughts around developing initiatives?
I have one, but I already told you.
Okay.
The initiative is kind of really detailed. This is what we need. This is how we're gonna fill it. This is the goals. So
Yeah. Yeah, I had the template, but again, the slides have somehow decided to stop. But I will send out the template as well so you can share
Yeah,
that.
I'll do that.
Because there's like an easier to understand template that you could fill in, or you can do the Survey Monkey. I like the template better, but I've made it, so. But yeah,
point,
and it doesn't have to be huge. It could be like a smaller initiative, and then we'll work to kind of roll that up into the larger. Like, if you think of that house diagram, like, does it fit into the primary care prevention? Is it workforce?
Others may have the same idea, then you're just actually making it better.
Well, and I think that because of the pace on this, we're gonna have lots of different people with good ideas, and it'll be like one of the next steps to be like, okay, let's all get together and start to refine to like a cohesive one for New Hampshire. Because like in full disclosure, we got like 6 different submissions for behavioral health workforce. And you're like, no, but we don't have, 6 weeks is a lot, that's really fast to get 6 different groups together to hammer out like a firm plan. So we're we'll probably do some of that fine tuning in the early stages of the grant.
Ask you, so like, when I think of rural, I have a vision of rural, but I think people forget that urban people have sometimes similar challenges. They're not included in this, correct?
So the eligibility for like where the funding can go is based on geography, but also types of facilities. So all QHCs are eligible. So that includes like Amoskeag or Lamprey down in more like urban areas, all community mental health centers, rural health clinics, critical access hospitals. Those are all, and I think doorways are as well. So those anywhere in the state are eligible.
You don't have to prove that they're they're just considered.
Yeah, they just get special status. And then there was something else I was going to say about it. I think as much as we can, we're going to try and like almost frame it too as like innovation and transformation is going to be driven by rural, but will be for the state. So I had to think through the crafting of that, but it's like kind of to my payer agnostic. It's like we should also just be like, if you live in New Hampshire, this is how you can, this is care, payer agnostic, rural, non-rural.
Does this go beyond healthcare to like social determinants from like food?
Yes.
Exercise.
Yeah.
Education.
Well, if you can imagine, the federal administration put a major emphasis on food and exercise. So as I had said before, like we have to have, if everybody in here maybe has a little bit of like PTSD from one of the policies that states are supposed to have that ties to like, I want to say $200 million for the 5-year period, is that we implement the presidential fitness test. So like sit and reach, flex arm hang,
We need to do that.
Yeah. So again, like, we're really thinking about like, how do we build something more around physical activity in schools? And then maybe that's just a piece of it. But then there's also like a requirement for CMEs for providers, like on nutrition. And then the SNAP waiver that I talked about. And we're definitely gonna do physical activity things.
And I think that some of that, I mean, I was a PE teacher 100 years ago, but we don't do well with state policy. Just never have. I mean, as you like, we're all out of
Remember dental
Yes, that's part of the primary care.
dental care, dude.
When you say payer agnostic, you mean you don't have to pay?
No, I mean, you're gonna get the same level of care whether you are uncompensated care, so that like you don't have insurance. You've got Medicaid, you've got Medicare, or you have commercial insurance. Because what ends up happening for like care delivery reform is that Medicaid's a great example. They just launched this new primary care model where they authorized a bunch of new CPT or codes that could be billed by providers. And those codes don't necessarily get covered by other like by commercial insurance. And so at a provider level, it's like a really tricky thing to be like, well, are we going to implement doing a health risk assessment with every patient when we know we're only going to get reimbursed from Medicaid? So that's where the need for the payer agnostic.
But if you had, if initiative was a rural dental health and you had a mobile dental van and it went throughout the North Country, but people really couldn't pay for the services, that might possibly be funded out of this. But you'd have to have some way to sustain it after 5 years, or could you just prove that, hey, we're in much better health because we don't have all this stuff going on orally, and that was the goal. And so even though we can't sustain this model, look at all the good we've done.
So the sustainability on that one would be to this idea of so we're gonna hopefully come to some sort of what's called a alternative payment model or value-based payment, where there's basically quality, like there are different providers need to hit in terms of measures. And they basically end up having to demonstrate savings, cost savings. And then the sustainability piece is if we get to a place where we say those shared savings that were generated from all the good preventive care, like giving some, and North Country is a great example. They disproportionately use the emergency room for non-traumatic dental conditions. So people just showing up because they don't have a normal provider for dental care. And so if you shift the cost from the emergency room into like an actual just dental, dentist office, you're going to save money. And then you could invest that saved money in providing free care. So it's a little bit of a.
Stop. They can migrate there.
Whitney, may I ask a question? Whitney, this is we're aware of a project that if folks are considering applying. How would we best boost that to you? Just email?
Yeah, email me or I'll send out my information. Email's probably best, and then we could have a call.
Okay, great. Thanks.
Just as a chair, I have to interrupt.
Yes, you do.
7 minutes left.
And then
We do have to have a public.
Yeah, so this is that time when we invite members of the public, #Ben and Bronwyn and anybody else we've missed that might want to make a comment now.
Was that enough?
You're not required.
Yeah, no, I feel like.
All right.
So I just want to know you were, this is the way I like to do it, is you're part of the entire thing.
Right.
I think, but, if you have an issue that's not directly related to what we're talking, or you want to bring it up to the committee this time. Yeah. No, I want you to talk.
Yeah, and as time goes by, again, we're talking about this as a publicly available meeting, you will have, I'm anticipating more people than just, these folks have a direct interest to have more public.
And I do apologize because I meant to say that at the very beginning, but you're a very important part of the entire meeting. And to say you have 5 minutes at the end, it's very easy.
Yeah. So I know we're running out of steam. I'm watching people on Friday afternoon kind of falling down, and we did extend it from an hour and a half to 2 hours. So I thanks for everybody for sticking with us. Any last thoughts, please feel free to share. We got a couple of minutes. While we wait for that, I'll put together the notes. I'm hoping that our recording is still good, even though my computer seems to be really just checking out on Friday afternoon. But we'll get you all that information. Go ahead.
There's just so many good comments in the chat,
Yeah.
so we don't miss.
I think we're good. We're still recording, so if not, I'm gonna get them all from memory again.
Oh, good.
You're kidding, really?
No. Well, yeah, bearing no new comments from Mystery Publics, we'll say goodbye. You'll see an email from me coming up pretty soon.
Did you lose the AI then on this thing too?
I don't know. We'll find out, yeah. So thanks, everybody. Yeah, reach out to me if you need to talk about anything. I'm here.
Thank you so much.
But we'll get you all this information we talked about today. And again, thanks for spending a Friday afternoon with us.
Every time we have a
Thank
forum,
you.
everybody.
Thank you.